Look, it's my pleasure to introduce our first keynote speaker today, who is Professor Lesley Dwyer, who is the Chief Executive Officer of the Central Adelaide Local Health Network, which is a large quaternary multi-site campus based right here in Adelaide, South Australia. There is a lot on her CV, but I'm going to let Lesley introduce herself. Thank you very much, Lesley. Please welcome her to the podium.
So, yes, there is a bit on my CV. My age is usually a dead giveaway that, I've been around for a little while. But I'm really delighted to be here today and really thank JBI for the invitation. I'd also, before I start, like to acknowledge that the land that we meet on today is the traditional land of the Kaurna people and pay my respects to their elders past, present and emerging. So as you can see, the topic that I'm going to speak to you about has got a very long title, which is Safety and Quality in an Evidence-Based Healthcare Culture, Organisational Leadership. As the Chief Executive of Central Adelaide, you would expect that I would probably talk a little bit about leadership. For those of you in the room and those of you that are Adelaideans, Central Adelaide is probably better known to you as the Royal Adelaide Hospital and the Queen Elizabeth Hospital, but we also have other sites as well, being Glenside and Hampstead. And in actual fact, there's a real strength in that multi-site approach and the diversity that we actually have, not just within the people that we provide care and services to, but also our staff. And so if I was to really distill down what I do want to talk to you about, because our journey has been well, I think, reported or chronicled from, being placed in corporate administration as a healthcare organisation 2.5 years ago, which is very unusual, not just unusual within the Australian context, but actually globally as well. But I actually want to start to really, I think, pull apart around, despite the best evidence, why does that actually at times not stop you from, not failure, but I call it getting into a little bit of trouble where you are not able to advance the right thing to do. And it really comes down to what are the behaviours that we actually accept, what are some of the norms, but what are some of the changes that we can make to try and get people back to, using evidence. And I was really, I think, taken by, what Zoe had said around the glocalisation, and particularly that quote around that the local context is really important as well. I returned to Central Adelaide from the UK, and I think everybody thought, oh, here we go, she's going to NHS eyes us all. And in some ways I have, because evidence is evidence. And if you see something that's worked well, you do need to think about, well, what's our local context and what do we do? So that's what I actually plan on talking about. I'm always so grateful when that happens. I'm just going to talk a little bit about evidence, because as we know, and I've just spoken about, that despite the availability of evidence-based guidelines, there are significant gaps in implementing evidence into routine clinical practice. And it's just as sticky and difficult as when you actually want to see translation of research into practice. And so what is it that actually stops us doing that? And I often, when I'm talking to people, particularly if we've got, something that, is holding us back, I have to determine, am I listening to opinion? Am I listening potentially to eminence? Or am I really listening to evidence? And so we went and actually had a look at, what's some of the evidence sitting behind why you don't see that translation, that change, that, implementation of evidence. And the Care Track Australia study, which was conducted to determine the percentage of healthcare encounters where adult Australians received appropriate care, the authors of that study suggested that without evidence of variations in care and poor compliance, we will always be unable to create sustainable systems. And most of us who work in health know that one of the things that we battle with is the constant starting, not quite finishing, starting on something else. We're very good at addressing a problem. We're sometimes not good at solving it because we're on to the next big thing. And so what that found was the appropriate care was provided really at only 57% of time of the encounters. And In fact, what Braithwaite et al. Identified was that only 60% of that care, on average, so it is averages, is in line with evidence or consensus-based guidelines. 30% of care is of low value or waste, adding no value at all. And there's a bit of a change in the funding system within Australia, and certainly within South Australia in this next financial year. We will no longer be funded for where there is evidence-based low value care. You're going to have to put up an argument about why you think that your opinion, eminence or evidence is actually different. And so I welcome that, because it starts a very useful discourse. So that's something that we're really keen to do. So we call this our 60-30-10 challenge. Oops, keep going. The care track data, which showed us the variability, and I know that this is a little bit hard to see, but you can see where there are pockets of excellence, as you can with coronary artery disease being well managed, about 90% of the time. So often when you think about the problems you face, you think, who's done this before? And what were the various components that they're doing? You know, what's the conversation that they're having? What's the evidence they're looking at? And what is that translation into practice that's allowed it to stick? And as we can see with coronary artery disease, it has been an area that I think has been well researched, well evidenced, and it probably says something about the culture there. But conversely, you can see that with asthma, which in Australia is a fairly common issue, health issue, patients being treated for asthma only receive appropriate care 38% of the time. And this is despite, and I know many of you will know about this, those asthma guidelines. People have been working on this for well and truly over a decade. I think in the paediatric area we've done extremely well, but not sure that we've done that so well for adults. So within our health service, sorry, there we go. Oh, see, I told you this is terrible for me. There we go. Phew. How do we improve on that 60% of time and have that impact on practice change? So the authors, as I said, of the Care Track study suggested that continuous improvement based on ongoing monitoring of the appropriateness of care should really become part, of the healthcare, an intrinsic part. We audit lots of things. We audit care guidelines, we audit lots of things that are not in the care spectrum. But in fact, how are we going to make checking that we're using evidence, that we're actually also growing evidence, to actually, lead to a change of practice, and make sure that we monitor and feedback that evidence back to the clinical areas around where there is change. One of the things that I've observed over the years is most people actually don't want to not know how their competitor is going, and it's actually part of our psyche here as a nation as well. There is a little bit of competition, and it's not competition of shame. I live by some simple mantras in my professional life, which is, are we the best or are we the only? And my view is that if we're not the best, we need to partner with the best. And if we're the only, we better make sure we are the best. But how do you measure that? How do you look globally and say, who is doing this better? How can I get some uplift from that? And we think that it's actually logical. Most healthcare professionals are, educated. They're well trained. They are surrounded by other, logical people who are looking for evidence and reviewing their practice. And some professions do it better. But in fact, there is some evidence, which is that if healthcare practitioners were given feedback that what they were doing was inconsistent, that in actual fact they may change their own way of going about their care. But yet the evidence goes on to say that audit and feedback alone has not consistently been found to be effective. And so the Institute for Healthcare Improvement have developed a white paper around framework for safe, reliable and effective care in 2017. And what they've actually, in laying out that practical framework, have said that because culture and learning systems are both foundational to a framework for safe, reliable and effective care, it can be difficult to know or where to begin. And organisations need to have the culture to be able to do the learning and the need to do the learning to change the culture. Often when things go wrong in health, we're very good at doing that look back. But in actual fact, there's more learning about when you do that quick catch, or when in fact you have been able to make a change and in fact you are learning from what goes right, not what goes wrong. And that's a real shift in culture for us. And so what we're wanting to actually do within the Central Adelaide is think about the leadership that we have. And that's leadership at all levels. When I talk about leadership, I don't talk about an executive role, and we have changed our structure so that we have got clinician leaders at all levels in that organisation. And that's something I'm actually really proud of. But in choosing those leaders, and I have a clinical background, and perhaps I got my first roles because I was a good clinician. Did that make me a good manager? Did that make me a good leader? Probably not. But thankfully, many of us have good role models, and we go off and we actually try and, sort of expand our skill set. But strong leadership is essential to drive and prioritise safety by facilitating, but also mentoring. Often when things go wrong or we're getting stuck somewhere, I say get alongside. Make sure we're actually alongside, but start to look for the evidence there. Because often we just jump in at everything, we try about 10 things, hopefully one of them will work. Very difficult then to go back and say, so which one made a difference? And it's not about a cookie cutter approach, it's actually about using evidence, using those guidelines, because it's a very different, thoughtful and considered discourse, rather than, I think we should, I have. It is around, what does that tell us? How would we do that here? So for the purposes of this presentation, I'm going to focus on the impact of culture in becoming, often used, a highly reliable organisation. I always know that people within Central Adelaide get the best of care when they are in front of you. But what about the people who aren't in front of you? And what happens if that doesn't happen every time? And so being consistent is really important. There we go. So achieving that safe and high quality care requires well-designed systems and well-functioning teams, and it very much is around the teams. Without addressing a culture of poor behaviours and performance that can undermine team function, improve systems alone, we can change lots and lots of things, but unless you actually manage the way that the team works and really make sure that that is the primacy of all that we do, you're never ever going to change what often is a steady state of entrenched behaviours and cultures. There's been lots of reviews done, and I want to draw your attention to the third one there, which is from William Cooper. Bill Cooper is from the University of Tennessee, so Vanderbilt. In 2019, after a decade of looking at the impact of behaviour on outcomes and experience of patients, found a positive link between surgeons who had a higher number of co-worker reports about unprofessional behaviour and the risk of surgical and medical complications. In short, that in fact, if your behaviour is not as it needs to be, which is around working as part of the team, sort of a bit like the airlines, we do expect that the co-pilot will say, Captain, I'm taking over the plane if you're heading for a crash. And we've put in lots of systems within health, and we've picked that up from aviation, but would you believe also from the motor industry, around, that reliability, that everybody has a role in that safety. And yet we've struggled yet again around what is accepted practice, surgical timeout. Can I say it happens 100% at Central Adelaide? No. But it's not an opt-in, opt-out. And what is the role of co-workers in saying, we're not starting, this is what we need to do? But what Cooper went on to find is that complication rates were also 14.3% higher for patients whose surgeon had 1 or 3 reports about poor behaviour, and compared with surgeons who had no co-worker reports. And this is when I describe it as somebody doesn't have your back. So you're off, you're in a bit of a, temper, or things haven't gone well. And yes, in healthcare, sometimes things, do stress people, but no one has had that person's back or given feedback to say, I think you're heading for a little bit of a disaster here. Gerald Hickson, who is the Senior Vice President for Quality, Safety and Risk at Vanderbilt, stated that even though there was only a 14% difference in adverse outcomes between patients being cared for by the most respectful and least respectful surgeons, if you took those numbers and distributed them across the US, where there are 27 million surgical procedures done every year, that could represent more than 350,000 surgical site infections, urinary tract infections, sepsis, all the things that we know that can be avoided when surgical teams work well together. And this has been repeated, not at those numbers, in the surveys that have happened, the numerous surveys across Australia about a poor behaviour culture in healthcare. And I just want to talk a little bit about that. It does get better. We do have a way forward, by the way. So the culture in the Australian healthcare environment, in 2015, the Royal Australasian College of Surgeons found that 49%, so just under half, of surgical fellows, trainees, international medical graduates had been subjected to discrimination, bullying, harassment or sexual harassment. And 2 years later, the College for Emergency Medicine, so these are our ED clinicians, found that 34% of its members had experienced bullying as part of their training. And there's been some fairly well publicised cases where trainees have been removed. And that doesn't just happen here, it actually happens across professions, but certainly in other countries as well. And so if we think about the South Australian experience, some of you will be aware that there was, sort of the Independent Commissioner Against Corruption, ICAC, in 2019, found that over 50% of South Australian health participants reported personally encountering bullying and harassment in the last 5 years. That report was actually titled Troubling Ambiguity. And so it's actually, well available on their website, and it makes a really interesting read around where, in fact, behaviour, sort of eminence, opinion, have really taken over what had been about good evidence and good teamwork. And the AMA Hospital Health Check found that, a wide range of doctors in training had personal experience of bullying or harassment. So to address psychological safety, we've identified the need to focus on team and organisational culture and the role that mentors and clinical directors, supervisors of training, play in supporting psychological safety. When we were first placed into administration, one of the very first groups that we established was a group called the Leaders Within. And these were people who would not have normally positional power, but they were the voice of what is actually happening out there, what happens in that direct patient interaction, what happens after hours. And they've really started to lead us into some really useful work that could happen. And we've also tapped into the work, and I do want to acknowledge the work that Michelle Tuckey from the University of South Australia has done in regard to role clarity, team function and avoidance of ambiguity as these drives dissent, which creates a substrate for conflict. And that her work reiterates that peer review processes are much more powerful than top-down approaches. So what we've done is that we have actually picked up the work that Vanderbilt has done, taking into account our context, because often when we're saying, well, what about this? They'll go, oh, it's not going to work here. And we've said we want to stop that. It's not that it won't work here. It's what do we need to know to fit our local context. And so we are setting about implementing the Vanderbilt. It's called Promoting Professionalism framework. And it is actually about providing a safe process for reporting behaviours and concerns. But what it is based on is over a decade of evidence. So if I was to go to a group of clinicians and say, oh, by the way, we're going to teach you how to actually talk to somebody else about their poor behaviour, you can imagine how far that would get me. But what we go with is that evidence that I've already touched on about the impact that behaviour has with patient outcomes, patient experience, and equally as importantly, co-worker experience and the impact that we have on those who are joining our professions and coming through. And I'll just give you sort of where we have actually looked at, well, what are some of the things that we do, that we can actually look to? Because in fact, they found that if you implement this immediate feedback that just want you to think about, that 71% of recipients who receive an intervention for a pattern-related behaviour were never ever named again, because nobody actually gets out of bed every morning to come to work and say, how can I make my co-worker's life a living misery? I'm sure they don't. Or how can I do something that potentially does not provide a better patient outcome? We know that. but in fact sometimes life gets in the way, systems don't work well, and it's based on the premise that everybody wants to do a good job, and sometimes we don't think about the impact of our behaviour on others. Where this has been introduced around the world, in fact, hand hygiene, and I'm sorry to sort of take it down to something but it's so fundamental, and if anything COVID has taught us, that was probably something that kept us so safe, that where they have actually put this in place, the compliance went from 50% to 95%. So it was actually about our behaviour as doing those things that we know create a safe environment, doing those things that should be ritual, habit, and we don't even need to think about. And that compliance has stuck for more than 3 years, because you don't want to do these things that are just, sort of fly by night almost, and then you go on to the next thing. So the framework, it's actually around, I watch something happen, and then we do train people to be the messenger, because you don't take on the problem. But I might sit down next to that person and just say, well, Bill, I noticed that happened. But in fact, I think you might have, created some problems there, and I just want you to reflect on it. We've trained now over, I think it's about 25 people, so we have a good alumni. And you can see that there's a graduated pattern, and obviously if there's something is so fundamentally just the wrong thing to do, they call it the cup of coffee conversation, which is just have a cup of coffee. Where I've seen this introduced, I have to say the sales of coffee went down tremendously. Nobody wanted to have a cup of coffee with anybody, so you have to make sure you say what sort of cup of coffee it is. But in fact, those 4 levels of intervention, some people will immediately get to level 3, and they don't get to have a cup of coffee, they'll get something far stronger, at that point. But in fact, it is very much about going back and looking at the evidence. So this isn't just, there may be, an isolated report, but what you do is you look for patterns. You look at patterns through your safety learning system. So what incident reports have we had? What have we seen in the complaints that might be attributable to that unit, to that person? What is happening there? So you're pulling out evidence so that when you are able to have that conversation, the first one is just want you to reflect. The second one is, there are some patterns here, and Vanderbilt have shown over the years that those patterns may show that what we have is a colleague in distress. Not a bad person, but a colleague in distress, and it may not be work-related. And so we have partnered now with Vanderbilt about that. But the 4 levels are depicted in this slide. We have seen this. I've been fortunate enough to go to Vanderbilt, but I've also been fortunate to roll this out in another organisation. But in fact, by putting this in place, as I said, 71% of people never get beyond the first cup of coffee. They've changed to tea or something. And you can see just the very small number that ever, by using this, proceed. Our HR processes, are there to protect everybody. But in actual fact, they are at times perhaps not really understanding what's sitting behind that. And from my perspective, what we need to do has something that as we roll this out, we talk about the evidence. And because they've been collecting evidence for more than a decade, this is something that our clinicians are really engaged in, because nobody feels good after, a terrible, terrible time, in going through, a complaint that may be, one that is actually signalling something that is much more distressing. So in summary, I think that it's really important that we do recognise, by using evidence, the impact of staff behaviours on a patient's safety culture and clinical practice. Leaders need to model what's expected and the standard to which we aspire, or as I often say, what we walk past, we accept. We need to actually be looking at the evidence that we collect every day, but triangulating it to say, is there something else happening here? So patient outcomes, reported behaviours of concern, and the College of Surgeons have also picked this up and will be supporting us in rolling it out. And no, we're not just rolling it out to the surgeons. We think that this is going to be a positive way to start to change the conversation from you did something wrong to let's look at the evidence, let's actually understand what's sitting behind this, because in fact the patient outcome, the patient experience, your co-worker experience is something that is really, really important to us. So we're going to kick this off. in July. We are going to be collecting evidence. We are going to be getting Vanderbilt to do that for us, because right now we want to actually get some leverage from others that have done this before. There are many places, sort of across Australia, who have introduced parts of it. And one of the things that I'm really keen that we don't do, and and it's not really flying in the face of what Zoe said about that, local context, is often things fail despite the evidence base when we take bits of them. And I'm a big fan, and as I said, I live from some very simple, almost, statements, which is lift and shift. Don't touch something that has a strong evidence base. Don't touch it for a couple of months. Watch it, quick catch if it's not working, but you might inadvertently take something out of that process that then makes it fall over. And so that's what we're going to be doing at Central Adelaide over the next little while. And this is what our ambition and our vision is at Central Adelaide. And it is very much about shaping the future of health with world-class care and world-class research. And when I saw, for Joanna Briggs, it is perfectly aligned. All of us are looking for the evidence that shows us how to do things better, that makes it easier for people to be their best selves. And we're hoping by looking at that evidence base around behaviour and outcome, addressing the behaviour, we're going to see a consistency in what we do, but more so a place that is actually about believing that our staff do want to do the right things, and when things go a little bit amiss, we're there to support them, to have their back as colleagues. Thank you.